CROI update. And we're really, really fortunate to have three phenomenal speakers that are not new to AIDS Clinical Conference. They've all presented before. And I'll start by introducing them and getting started on time, just because I want to make sure they have enough time to present all of the information that was presented at CROI, or the highlights, I mean. So Jehan Budak is an assistant professor at the University of Washington and assistant medical director of the Madison Clinic, and is also a co-editor of the National HIV Curriculum and does many other things, including lead the HIV pathway or training in our internal medicine program here. Julie Dombrowski, who many of you know as well, is a professor of medicine, also in the Division of Infectious Diseases. She is founder of the Max Clinic and also a provider at the Madison Clinic, and does many, many things, including her areas of research in differentiated care models, and really overall trying to improve the care for people living with HIV. And then Raaka Kumbhakar is soon to be assistant, well, she's actually already assistant professor, but transitioning to a clinician scholar role here, and is a core provider here at Madison Clinic and the director of our MOD Clinic, which is our moderate needs clinic in Madison. So thank you all, and I'll let you get started.
Thank you. All right. So good morning, everyone. Shrisha, thank you very much for the introduction. And I will be giving updates on treatment. I don't have any disclosures. And today, as you might notice, I'm really going to talk about the injectables. I always want there to be more content about treatment at CROI, but I think these are some of the key things. And I know that the rollout of injectables is difficult, and I recognize that. And but nonetheless, I wanted to share some of these updates in case it might help in any way in your practice. So first off, starting off with long-acting cabrylpivirine. These are the abstracts that we're going to talk about: the CARES study, the Latitude interim data, and then some real-world experiences from some posters from Ward 86 and about some virologic failures at the Chicago Clinic. And as a bit of background, as we all know, that the Atlas Flare and Atlas 2M studies demonstrated efficacy of long-acting Cabenuva or cabrylpivirine and led to FDA approval for those with viral suppression. And virologic failures in the Atlas 2M study had occurred at a rate of 2.3% in the Q8-week arm versus 0.4% in the Q4-week arm. And I like that piece of data because it really kind of shows perhaps the difference in frequency and potentially resultant virologic failures. But as I think most of us know, that clinical trials to date had not included persons with adherence challenges. In Atlas Flare and Atlas 2M, everybody was either sort of new to the injectables and then had to suppress, or previously suppressed. And then in addition, clinical trials to date had little representation from Africa, the entire continent. In fact, in Atlas and Flare, for each of them, there were approximately 120 sites, and they had 7 and 9 sites from Africa, and all of those were from South Africa. So not a varied representation from that continent. And the investigators from the CARES study, which we'll talk about, felt that specifically there wasn't much representation from the continent, especially amongst people who are predominantly mostly Black African women, have different subtypes of HIV-1, have high exposure to NNRTI and pre-treatment resistance, and have varied treatment strategies with potentially infrequent lab monitoring. In my experience from a district hospital in Kenya, oftentimes it would take 3 months for us to see the viral load results. So this is a slightly different sort of clinical setting. And so with that, the CARES study was a phase 3B randomized open label active controlled non-inferiority study where they took individuals who were over 18 on stable oral either TDF plus XTC, which is either 3-TC lamivudine or FTC emtricitabine, plus dolutegravir, nevirapine, or efavirenz, and had a viral load that was less than 50 at 4 to 12 months prior to and at screening, no history of renal failure, and no hepatitis B, who were randomized to oral ART, which was again their standard of care, or to be on cabrylpivirine every 8 weeks with an optional 4-week oral lead-in. The HIV viral load was checked every 24 weeks. And so, yes, that is every 6 months. And resistance analysis was performed at 48 weeks due to their public health approach to enrollment. So a proviral DNA was performed for archived resistance on stored PBMCs. So again, to clarify that, basically it's not, people were randomized without the genotypes or the history. And then at 48 weeks, they sort of took that pooled blood or that stored blood and ran it for proviral DNA. And the study sites were in Uganda, Kenya, and Tanzania, so much better representation from other countries in the continent as compared to an Atlas and FLAIR. And these are the baseline characteristics. In general, they were a well-matched study. There were 57% of people who were of female sex. The age was about 42, median was 42. Interestingly, about 21% had a BMI greater than 30, and I was unable to find any differentiation between that BMI. Was it mostly just 30 to 40 or higher? And the other thing that I would like to draw your attention to is the next few rows, where the time on first-line ART was 8 years, a median of 8 years, and 75% had prior exposure to NNRTI. So this is a heavily treatment-experienced cohort, and 92% were on an INSTI regimen at screening. And then you can see here, based on archived DNA analysis, which we know is very specific, but not very sensitive, showed that 56% of individuals had a HIV subtype A1, and about 13% had rilpivirine resistance mutations, 16% had CAB resistance mutations. And so when I was hearing about CARES and listening to this, I remember feeling a little bit nervous about what the findings might show. However, they were good. The long-acting CAB rilpivirine demonstrated non-inferior virologic efficacy as compared to oral standard of care ART. And here you can see in the graph, in the middle, where it in blue is the CAB rilpivirine and gray is the oral standard of care, that about 96 to 97% of participants had virologic suppression, which they defined as less than 50 copies per milliliter. 73% of individuals had an injection site reaction. That satisfaction increased for those who switched to long-acting CAB rilpivirine, and that 96% of scheduled injections occurred within the 7-day target injection date. I know this is some, at least for those of us who are trying to implement this, important information, because it's helpful to know how many people came in on time and how many people would you have to call many times. And there were 2 cases of virologic failure with a virologic failure rate of 0.4%. And here is a slide from clinical care options on some of their CROI report back information that tells us a little bit more about that virologic failure. Here you'll see, even though I said that there were 2, you might say, Jehan, this says 1. And there was actually 1 additional virologic failure, which was unconfirmed in a deceased person. But we had some data about that said deceased person. And in these 2 individuals who had virologic failure, they had no delayed injections. Their BMI was low. One of them had subtype A1, and the other had subtype D HIV. And the first individual here had no resistance mutations at baseline, again, based on proviral DNA. And this person had resistance mutations at baseline of a K103N, which is allowed in the Atlas and FLAIR studies, but an E138A, which is not. And they, as you can see, that they both failed with both INSTI and NNRTI resistance. So my conclusions are that at week, well, not mine, CARES' conclusions are that at week 48, long-acting CAB rilpivirine every 8 weeks administered in sub-Saharan Africa in a public health setting was non-inferior in virologic efficacy to oral standard of care, had a good safety profile, and was well tolerated. That only 2 cases of virologic failure occurred in the long-acting CAB ril arm, both with emergence of INSTI and NNRTI resistance, and that in demonstrating safety and efficacy of long-acting CAB ril in sub-Saharan Africa using their public health approach, that CARES 48-week results are a key first step in implementation in this patient population. And I personally am looking forward to the 96-week data to see if I can be less nervous about individuals on CAB rilpivirine. The other study that I wanted to be in depth about was the Latitude study, which is a phase 3 prospective randomized open label trial and design that we had here at our positive health research arm participate in. And so I think for a lot of us, it feels very much on the sort of cusp of our mind. And we got some interim data at CROI. And so this was a study for persons with HIV who have barriers to adherence with poor viral response despite oral ART for at least 6 months, or who are lost to follow-up with ART non-adherence for greater than 6 months, without hepatitis B and no INSTI or rilpivirine resistance-associated mutations historically or by screening. So step 1 was where people were placed on oral standard of care, plus received conditional economic incentives. And then once they were suppressed, were then randomized to step 2 here in the green, which is arm A, cabrilpivirine, long-acting every 4 weeks, versus arm B, a standard of care ART, with the plan then for step 3 to be another 52 weeks of cabrilpivirine long-acting Q4 weeks. And their primary outcome was going to be regimen failure, defined as the earliest occurrence of confirmed virologic failure or treatment discontinuation in step 2. So this is aside from Adia Rana, who was the primary investigator, and they have sort of highlighted things in red that are key, that 20% of individuals were less than 30, that 30% were assigned female at birth, 5% were on the transgender spectrum, 64% were Black, 17% were Hispanic or Latino, and 14% had a history of infectious or injection drug use. And that you'll see 14% of individuals had a viral load greater than 100,000. And then in step 2, when individuals were randomized, and supposed to be undetectable, there was still a proportion of individuals who had a viral load that was greater than 200 in both the CAB-RIL arm and the standard of care arm. And these are their interim data. And basically, if you can just sort of, there's a lot on the slide, but you can see here that they're, for the primary outcome, which was regimen failure, it was not statistically significantly different. But on the secondary outcomes of virologic failure and treatment-related failure, that there was a statistically significant difference in that the cabrilpivirine was better than the standard of care. And I think that a lot of us assumed this, that in someone who has a hard time taking pills, that giving them a shot may be better, but it's helpful to see this data. And then I'm particularly interested in this longer term data to see what happens again in step 3. So based on these results, we also got some more information about injection site reactions that occurred in 57% of individuals, that 93% were on time for their injections, 3% missed their injections, and that there was confirmed virologic failures, 6 in the CAB-RIL arm, 28 in the standard of care arm, and there were 2 with resistance-associated mutations in each arm. And here I have highlighted the resistance that people who were on the CAB-RIL arm failed with. So with pretty high-level INSTI resistance and some and an RTI resistance. So in persons with HIV with adherence challenges, long-acting CAB-RIL every 4 weeks showed superior efficacy to oral standard of care in their secondary outcomes, and specifically there were fewer virologic failures and treatment-related failures. And then on February 12th, given these key secondary endpoints met stringent stoppage criteria, the DSMB, or the Drug Safety Monitoring Board, recommended halting randomization and offering all eligible participants to switch to CAB-RIL. And the data supports the use of long-acting CAB-RIL in populations with adherence challenges. So now let's move on to some lightning round slides. So Ward 86 abstract of week 48 results. You might recall last year that I shared some of their data about their 55 out of 57 individuals without viral suppression who achieved viral suppression at a median of 33 days with a virologic failure rate of 1.5%. And that now they have 286 patients on long-acting CAB-RIL, and 59 were included in their week 48 analysis. And with regards to viral suppression, specifically, I focused on 59 who did not have viral suppression going into this, that 48 out of 59 or 81% remained on long-acting CAB-RIL and were virally suppressed, and that 93% got viral suppression on CAB-RIL plus an alternative ART, so combining that. And their virologic failure rates were 5% in this group, 2, which we already talked about at CROI 2023, and then another one following self-discontinuation of both CAB-RIL and not being interested in starting on oral ART afterwards. And then here are the 2 patients from, again, CROI 2023, and then this third patient here, and what are the mutations that they failed with. This is a resource for you all. And I did clarify with with Matt Hickey, the author of this abstract, that these were indeed the pre-treatment viral load mutations, that there is a bit of a typo in the poster. And so here, hopefully this is the correct information for you all. And then the other key bit of information was from virologic failures at a Chicago HIV clinic at Rush. Of 75 virally suppressed persons with HIV who were switched to Cab-Ril, 10 received it at an independent infusion center, 65 received it at clinic, and 3 virologic failures occurred at a virologic failure rate of 4%, 2 at the infusion center, 1 at the clinic. This virologic failure occurred at 8, 10, and 16 months, so pretty far into therapy. All were using a 1.5-inch needle, and all 3 switched to a PI-based regimen and achieved viral suppression. The individuals at the infusion center said it felt weird, but I'm not clear exactly what they described by that. And then here from their poster are descriptions of these individuals who were all receiving on-time injections and then failed with the following resistance mutations. Notably, patient 1 was someone who had perinatal acquisition of HIV and had a prior known M1-D4V and were on, I believe, the combination of Odefsey and dolutegravir beforehand. So maybe not exactly translatable to some of the patients we're putting on Cabenuva here. And then some quick lenacapavir updates so that Julie and Raaka can share. That as background, lenacapavir is a capsid inhibitor administered subcutaneously every 6 months, that the FDA approved this in December 2022 for MDR HIV, and this was informed by the Capella study, which was that when combined with an optimized background regimen in individuals with MDR HIV, lenacapavir subcutaneously every 6 months led to viral suppression at week 104 in 82% of people with HIV, which they did by a missing equals excluded analysis. And I think based on the Capella and the Calibrate study, we know that len has a low barrier to resistance with the M66I as the signature capsid mutation, and that len resistance in the studies were associated with inadequate adherence to the optimized background regimen, which is whatever ART that the patient's on, and if the OBRs lacked fully active agents. So this group decided to assess len efficacy in Capella participants whose optimized background regimen had no fully active ARVs. So essentially adding lenacapavir to an optimized background regimen that didn't have any fully active ART. In Capella, I'll mention that here, but so what they did was that they calculated the overall susceptibility score from this optimized background regimen, that 12 of 72 had no fully active ARVs, 5 of 12 had an OSS of 0, 6 of 12 had an OSS of 0.5, so had only half of a susceptible antiretroviral, and then 1 of 12 had an OSS of 1, where they basically had 2 partially active ARVs, so they at least had 1 active agent. And in Capella, the median OSS was 2. And this was a heavily treatment-experienced cohort with a median of 4 agents in their optimized background regimen, with a baseline mean viral load around 10,000 and a baseline mean CD4 of 175. This I'm just showing to show you that these are their resistance mutations at baseline. This was a heavily treatment-experienced cohort. I'm putting this up here in case any of you have those patients where you're scratching your head, figuring out, like, what are we going to do for them? And here are some individuals whom I'm sure people were scratching their heads. So from this poster, 8 of 12 suppressed at all 3 visits, and of the 4 not suppressed at all 3 visits, 3 of 4 developed an M66I at weeks 4, 4, and 10, respectively. So pretty early on into treatment with len. 1 of 4 never achieved viral suppression, but interesting, and then the lack of viral suppression prompted changes to their optimized background regimen. The mean increase in CD4 cell count was 105. And here's the thing that I thought was interesting, that none developed treatment emergent resistance to their optimized background regimen through week 104. So that's great and fascinating. So when considering len, I recommend that you look at this table, look at this poster and look at tables 1 through 3 and figure 2, because I think that it's, again, really helpful to see patients who have been through this before and see what is working for them. And then 2 other things I wanted to end on is that at Ward 86, they, with 3 other clinics, put together a case series of 34 patients using off-label len and cab with or without rilpivirine. So basically combining len plus Cabenuva and sometimes tossing the rilpivirine aspect of Cabenuva for selected patients with adherence challenges at Ward 86, not 96, UCSD, Metro Health's HIV Clinic, and UPenn. The patient characteristics were as follows, and you can see that 29% were on CAB every 4 weeks and 71% were on CAB every 8 weeks, and that they used this len plus CAB with or without long-acting rilpivirine based on an RTI resistance if they had rilpivirine RAMs, INSTI-RAMs, high viral load, or continued viremia on Cabenuva alone. And they have a very big, rich table with 34 patient data. And then they had injection site reactions in 44% of patients, and 94% had viral suppression, up from the 47% that were suppressed at baseline. And they have a call for a trial. So I think we will see more about this combination in the future. And then last, that this is a phase 2 trial of once weekly oral islatravir plus oral lenacapavir, comparing it to Biktarvy in persons with HIV who are virologically suppressed, and that viral suppression was achieved in 94% of participants at 24 weeks and was well tolerated, that there was no significant difference in changes in the CD4 cell count or absolute lymphocyte count with islatravir, because you might recall that islatravir initially, still causes a CD4 and absolute lymphocyte count decrease, but we're not really sure how clinically significant that is, and is improved with dose reduction. So basically, this is a once weekly oral islatravir and oral lenacapavir that is in a phase 2 trial. And so I think that we'll see more long-acting regimens that are not just injectable. So in conclusion, the week 48 CARES data demonstrated that long-acting Cabril was non-inferior to oral standard of care in sub-Saharan Africa, that it was also superior to oral standard of care in key secondary outcomes in the Latitude study, that long-acting Cabril appears durable, but real-world virologic failures are maybe more in the 4 to 5% range as opposed to 0.4 to 2% range, that len, even when combined with no fully active agents in the optimized background regimen, was efficacious in 8 of 12 participants from the Capella study, that the combo of len plus cab, maybe also RIL, provided efficacious in 34 patients, and we will likely see more data about this in the coming years, and that's still in phase 2, weekly oral islatravir plus len has the potential to become a long-acting option for persons with HIV. Julie. Thank you.
Thank you so much, Jehan, and good morning, everybody. I'm pleased to be here to present some highlights of prevention from CROI this year. My disclosures are shown here, and I'm going to cover 2 main areas of prevention, doxy-PEP and HIV PrEP. For doxy-PEP, there were a number of abstracts presented that showed us the final results of clinical trials, some data on impact of use in clinical practice, and preliminary data on antimicrobial resistance. So the first of these is a follow-up to one of last year's presentations. This is the final results of ANRS 174 DoxyVac trial. This was a multi-center 2x2 factorial randomized open label trial that looked at 2 key endpoints. First was the impact of doxy-PEP on time to first episode of syphilis or chlamydia. And second was impact of the multi-component serogroup B meningococcal vaccine on first episode of gonorrhea. You may recall last year this was presented shortly after DSMB stopped the study, and both of those endpoints were reported to be significant. After that, the group reported that there were some issues with the data found in an audit, that the gonorrhea endpoints weren't fully ascertained. So this is now the updated and final results from the study. On the left, you can see a graph that shows the time to first episode of syphilis or chlamydia, and there was a very substantial reduction of 83% with doxy-PEP in that combined endpoint. Looking at those separately, there were also reductions in both outcomes. For time to first gonorrhea infection, doxy-PEP also reduced that by about 33% with a significant p-value. That again wasn't expected, in part because tetracycline resistance among GC strains in France and in Europe is so high. And unfortunately, the meningococcal B vaccine upon reanalysis did not have a significant effect. It was close, as you can see from that confidence interval. So the investigators essentially concluded that they can't rule out a small effect, and we will get some more data from ongoing trials of Bexsero for GC prevention in the US. Looking at tetracycline-resistant GC among people who acquired GC during the study, they found that a lower proportion of people not on doxypep had high-level resistance compared to people on doxypep. That again mirrors what we've seen in other studies, and that was a significant difference. The next clinical trial reported was an extension of the doxypep study that showed sustained reduction of bacterial STIs. So as you may recall, the doxypep study about 2 years ago reported a 65% decrease in quarterly STI rates among MSM and transgender women. The DSMB stopped the study in May of 2022, and at that time, all participants were notified of the results, and participants in the standard of care arm were offered doxypep. Interestingly, but I suppose not surprisingly for people in a trial, almost everyone in that group accepted doxypep. And then this looks at the results of those groups during that extension period. And what you can see on the left is the as randomized results, again with that 65% reduction. And in the open label extension, when the standard of care folks were mostly on doxypep, here, it was results very similar to the clinical trial. So that is reassuring. Okay, so what about real world use? In San Francisco, doxypep was rolled out in November of 2022 in several clinics after release of guidelines in October that really strongly recommended doxypep for the population included in the study, MSM and trans women who'd had a bacterial STI in the past year, as well as essentially permissive use for people outside of that population. So we have 3 abstracts from San Francisco that look at the impact on STI rates in more of a real-world setting during that time. The first of these was from Hyman Scott and colleagues looking at data from Magnet Clinic at Strut. That is a sexual health clinic run by San Francisco AIDS Foundation. They did an interrupted time series analysis of quarterly STI, an outcome very similar to the doxypep study. That analysis is somewhat difficult to describe and display in detail. So what I've shown you here is one figure that I think distills the results, which is STI rates, again, in the first quarter of that time versus the 5th quarter of that time, among people who were offered and elected to start doxypep. That reduced from 18% to 7.5%, and no doxypep stayed essentially similar. So it's encouraging both that higher risk people were electing to start doxypep, or people with higher rates of STIs during the pre-analysis period, and those looked similar to the non-doxypep group in the post-analysis period. In the table, you can see the incidence rate ratios, and essentially it reduced chlamydia and syphilis. There was no impact on gonorrhea. Similar results from the San Francisco City Clinic. So this is the municipal STI clinic. They looked at the pre-analysis period, essentially the year before November 2022 and the year after November 2022. They implemented doxypep in their clinic and offered it widely to everyone on taking PrEP, as well as other people who were interested. Here they're comparing positivity, so not overall rates, but among all people on PrEP with or without doxypep who had tests, what was the proportion positive? The chlamydia figure is shown at the left, where there was a 90% decrease, syphilis a 56% decrease. Both of those were significant. As you can see in the no doxypep group, there was also a decrease in the pre to post. For chlamydia, that was substantially higher among the doxypep users. But similar to Magnet, there was no significant decrease in gonorrhea. There was a slight decrease, but it was not significant. And finally, population level data in San Francisco. There were 2 abstracts that looked at, again, pre-post doxypep guidelines, but now we're talking about the entire city's data. And of course, since we looked at those 2 clinics, which see a large proportion of the population, it's not surprising, but results were quite similar. At the same time, it's remarkable that we have some impact of decreased STI rates at the population level in a city with high uptake. So they did, again, just an ecological analysis and looked at before and after. They restricted the before period to the time when most of the impacts from COVID appeared to have dissipated and things went back to normal. They estimated that 3,700 people were on doxypep by the endpoint of this analysis, representing about 20% of MSM and trans women in San Francisco. And what they saw was a 50% decrease in chlamydia, not shown here. At the same time, there was no change among cisgender women in chlamydia cases. Syphilis decreased by about 50%. Gonorrhea did not decrease, and in fact had a significant increase in the post period. All right, well, with all this doxypep, of course, one of our biggest outstanding questions is the impact on the microbiome and antimicrobial resistance. So this is some data relatively early, looking at the impact of doxycycline on the gut microbiome and antimicrobial resistance genome or gene expression, resistome. And this was from the doxypep study. Participants collected swabs at enrollment, and at 6 months, the group did DNA and RNA metagenomic sequencing. From the group of people with the highest reported levels of doxypep, where you'd be the most likely to see this, or resistance compared to standard of care. Looking at the microbiome as a whole, there was no difference in bacterial diversity and total bacterial abundance, but there was a difference in tetracycline antimicrobial resistance gene expression. So in this figure, what you see is tetracycline at the right, with a significant difference at month 6 between doxypep and non-doxypep users that was not seen with any other class of antibiotics. This is a different way of looking at this, essentially a dose-response relationship, and indeed, doxypep was associated with a dose-dependent increase in tetracycline antimicrobial resistance gene abundance. So in summary for doxypep, we know that it decreases STI rates in MSM and trans women. There's a clear impact on chlamydia and syphilis, both in clinical trial and practice data. The decreased gonorrhea risk that was seen in both trials does not seem to have translated, at least in San Francisco, to decreases in practice. Scale-up occurred very quickly in San Francisco, high level of interest in the intervention. And with some preliminary short-term use, doxypep does not appear to impact bacterial diversity in the gut, but is associated with dose-dependent tetracycline AMR genes. All right, so let's switch over now to HIV PrEP. I want to briefly review some novel formulations, public health impact, and encouraging data on cis women. What's in the pipeline? First, a weekly oral medication similar to what you heard from Jehan's presentation with treatment. This is an NRTTI phase 1 study done dosing and safety for PrEP. And essentially it was safe, it was well tolerated, and the PK profile showed that with doses in the higher part of this range, that supported weekly or even less frequent dosing. So weekly oral is coming. Longer acting injectable. This was the company essentially that makes the approved cabotegravir product looked at a reformulation, adding a human hyaluronidase to make it longer acting, as well as a new ultra long acting formulation of cabotegravir. Also a phase 1 study, intramuscular version was very well tolerated, and the dosing interval can be at least 4 months, if not longer. As you can see there, this goes all the way out to 52 weeks. So likely in the pipeline, a 4-month, Q4 month or less frequent injection for PrEP is coming. And finally, an annual PrEP. So this was a study looking at an annual TAF implant, again, first in human study, 48 weeks. This, unfortunately, what they found was that it was not very tolerable. You can see the implant site reaction frequencies and types on the right here, and 31% of people in the study needed it removed early at a median of 19 weeks for tolerability. There was lower than planned drug release, but optimism that we are heading down this path, and hopefully it can be engineered to release drug at a way that gets it to the right concentration and become more tolerable. Okay, at the same time, it's always worth remembering we already have a very effective option for PrEP that is very inexpensive now that it's available in generic form. This was a study looking at whole US led by Patrick Sullivan and colleagues. Again, ecological study between PrEP coverage and new diagnoses. So of course, there are many, many other things, most significantly structural factors that affect rates of new diagnoses and PrEP coverage. They looked at PrEP use using commercial data sets and PrEP coverage essentially being the number of PrEP users per 100 persons with indications. What you see on the left is this big increase in PrEP over that time without, unfortunately, a very substantial increase in viral suppression. And on the right, with separation into quintiles of PrEP coverage among the group with the highest PrEP coverage, they also saw the biggest decrease in HIV rates. So again, very encouraging for prevention, but discouraging in terms of the profound disparities both in PrEP use and HIV diagnosis rates. Okay, switching now to cisgender women, who I didn't address in DoxyPEP in large part because we don't have any new data in that group, although there was certainly vigorous discussion about this at several of the DoxyPEP sessions. Here we're talking about HIV PrEP in cisgender women, and we've known for a while from IPREX and subsequent studies about the PrEP adherence response relationship for MSM. Essentially, you don't have to be perfect. Something around 4 days a week usually gets adequate concentrations to prevent HIV. So this was a study by Kenneth Magwanya and colleagues looking at tenofovir concentrations in both dried blood spots and peripheral blood mononuclear cells in women who were taking directly observed meds. And they looked separately at pregnant and non-pregnant women. So what you can see on the table is the results from the persons getting 2 doses per week, 4 doses per week, and 7 doses per week. Encouragingly, no difference in PBMCs, where it counts, between pregnant and non-pregnant, although there was some difference in the dried blood spots. And concentrations in the 4 and 2 per week group that were very similar to what we're seeing with MSM and trans women in the US. So that is encouraging. There was a great talk by Janelle Stewart, who was looking at really the larger issue about challenging dogmas around event-driven PrEP and PrEP more broadly that touched on this same issue. And she showed this great slide highlighting a recent publication in JAMA led by Jeannie Marazzo and colleagues that looked at trial data, so pooled data from 11 studies among cisgender women in 6 countries, and found, similar to the results we've seen in MSM with IPREX and to the information from PBMC concentrations we saw in the last study, that both perfect adherence and taking 4 to 6 pills per week were associated with significant reductions in HIV risk. So Janelle asked the great question, do vaginas demand perfection? The answer to that is no. So this is all very encouraging for HIV PrEP among cisgender women. And that's the end of my slides. Thank you very much. Over to you, Raaka.
All right. Okay, so thanks so much, Julie and Jehan. I'm going to end with switching gears a little bit and thinking about co-occurring conditions for people with HIV. So I'm going to go through a few kind of disparate issues. One is updates in anal cancer screening strategies. Then we'll go through some metabolic complications of HIV and specifically with regards to semaglutide. And then we'll close out with updates in Hep B vaccination and Arm A of the Beehive study. So starting off with anal dysplasia screening. We know that the incidence of anal cancer is high among people with HIV, and it's particularly so among men who have sex with men. And we've all thought about and talked about the Anchor study that came out in 2022 that really showed us that treating anal HSIL or high-grade squamous intraepithelial lesions reduces incident anal cancer. That's a 57% reduction. The thing that's come out of that since is that HRA, high-resolution anoscopy, is the gold standard for HSIL detection, but availability is really, really limited, even in our high-resource settings. So we need practical strategies to approach anal cancer screening in people with HIV. And that might be, and this has been up for discussion for some time now, prioritization of referrals by demographics, So age being MSM, having a low CD4 nadir, cytology results, and then high-risk HPV results. So this first study in this session was an evaluation of the performance of different HRA triage strategies in MSM with HIV. And the goal was to really determine the quote-unquote best strategy for HRA triage in men who have sex with men to efficiently allocate resources. So this group looked at 180 MSM with HIV who had anal cytology, HPV, and high-resolution anoscopy performed on the same day. You can see in this group that the age was 47, CD4 nadir was 350 as a median, although with a wide spread, but a very high current CD4 count and CD4-CD8 ratio. These men were virally suppressed. If we look at the cytologic results, you can see that the majority, 69%, had LSIL or low-grade lesions. And then the next results I want to highlight is that 75% of these individuals had a high-risk HPV strain. And of those, 54% had HPV 16, which is the strain most related to progression to anal cancer. Then I'm pointing out that there's 43% of those who had their HRA done had histologic HSIL. And these are categorized now as our true positives in the study. And I'm pointing this out because with all of these results, they made various combinations of hypothetical thresholds for referral to high-resolution anoscopy. And so that's what we're seeing here. So we have sensitivity versus 1 minus specificity in this ROC curve. And then in the bottom right corner of each graph, that's the number of HRAs that would have been triggered with each of these respective thresholds, which is the title at the top of the box. And so we can see here in the conclusion of the investigators is that the best combination of sensitivity and specificity was high-risk HPV testing with 87% sensitivity and 63% specificity, which gave us a positive predictive value of 65% and negative predictive value of 85%. They did point out, though, that there's various combinations of anal cytology and high-risk HPV that seem feasible. And we can see as this addition dropped sensitivity, but increased specificity. And I think the conclusion that they presented that I thought seemed really reasonable is that when we think about periodic screening that we would generally have for these men, we could improve that sensitivity over time. So the next poster I wanted to highlight is CD4 nadir and anal cancer risk. And again, the big takeaway here is something that we knew from Anchor and maybe some other studies, but I thought this was really striking in this poster, that this looked at all treatment-naive people with HIV over 16 in a region in Spain to look at incidence rate of histologically confirmed anal cancers. People with HIV with a nadir CD4 count less than 200 had the highest anal cancer risk with an adjusted incidence rate ratio of 29 versus those with a high nadir. Those people with HIV with a high nadir had similar risk as compared to the general population. And what you can see here on this plot is that age, MSM, and low nadir CD4 count had the strongest association with anal cancer risk in people with HIV. Finally, I'll highlight an oral abstract, anal self-sampling for high-risk HPV detection. And so we have talked a little bit about getting cytology, getting high-risk HPV strain typing, and getting HRA, but cytology even might be limited in certain settings, such as sub-Saharan Africa. So this study was conducted in Togo and was an evaluation of anal self-sampling, or ASS, and I did not come up with that acronym. That was the study authors, for high-risk HPV detection as compared to anal swab by practitioner, or ASP, in 188 men who have sex with men, 67% with HIV in Togo. And so the practitioner would conduct that anal swab and then an anal exam and anal cytology post the sampling. What the big takeaways are, this was very acceptable. So it was procedurally easy and more people preferred ASS to ASP. Performance, so how good the sample was pretty similar in both groups. And there was substantial agreement between the methodologies. So whether self or provider sampling, very close concordance. So nearly 90% for high-risk HPV in general and 90.3% for HPV 16. And the presenter noted that all discordant HPV 16 samples had low viral loads. So I think there's some other data here about how frequent high-risk HPV was detected, which I think kind of checks out in terms of our ecologic understanding of HPV. But I think the big takeaways are that there's high concordance between these sampling methods. It's really acceptable. It's really easy. And this may really help us achieve our anal cancer screening targets, especially They said low and middle income countries, but I'm thinking about some of our low barrier care settings as well, where conventional care may be less simple. So takeaways from anal dysplasia, really this is thinking about considering how to develop guidance for HRA referral, which we are awaiting the OI guidelines, anal cancer screening guidelines. ENs, the international guidelines, were updated at the end of January this year and really take into account a lot of these factors. So high-risk HPV typing, anal cytology, and then some of our demographic information. All right, so switching gears, we'll move to metabolic complications. And originally I had a lot of thoughts. There's a lot of good stuff at CROI about some of these, but I really wanted to focus on GLP-1 receptor agonists. So as we know, these have had great success in people with diabetes, with promoting insulin release and suppressing hepatic glucose output. And then semaglutide specifically, among others, we've really talked about in both diabetes and people without diabetes as a drug to help with weight loss and cardiovascular outcomes. What we don't know is the impact of semaglutide in people with HIV, who may have more of these metabolic kind of comorbidities. So the SLIM liver study was a study looking at metabolic dysfunction-associated steatotic liver disease, or MASLD, which is common among people with HIV. We know there's a higher prevalence of NASH and hepatic fibrosis that have been observed in people with HIV versus those with primary NAFLD. And GLP-1s and semaglutide specifically are associated with metabolic improvements, including improved hepatic steatosis. So knowing this, those who conducted the SLIM liver study were looking at the effects of semaglutide on liver fat. And so they performed MRI proton density fat fraction, or MRI PDFF, to quantify intrahepatic fat, or IHTG, which is specifically triglyceride content. And what I learned is that this is really an acceptable biopsy surrogate for hepatic fat. So they looked at 49 people with HIV who were suppressed and had an elevated minimum waist circumference, high levels of insulin resistance, and greater than 5% IHTG on MRI PDFF. And these individuals were initiated and up-titrated on semaglutide. And then the MRI PDFF was performed again at week 24. And so I listed some demographics. I did want to highlight that the median BMI was 35, median CD4 was quite high, and more than 80% of these individuals were on integrase inhibitors. And so what you can see here, they had given us both absolute and percent change, and I have the plot for percent change up. So there was an estimated decrease of 31.3% in intrahepatic fat. 58% of participants had a greater than 30% relative reduction in that IHTG. Nearly a third, so 29%, had complete MASLD resolution, which is an absolute IHTG of less than 5%, which is usually correlated with histologic resolution. And you can see that these improvements really correlated with weight loss to a significant extent, along with our other metabolic factors. The authors did note that people who didn't lose weight didn't have that IHTG improvement. So it's definitely tied together. And this wasn't powered for subgroup analysis, but there were greater reductions in women and people who were Hispanic and non-Hispanic whites and participants over 50 years. There were a couple other abstracts highlighted discussing semaglutide and HIV, both oral abstracts. So there was another SLIM liver study that was presented that looked at specifically muscle structure and function. And the idea is that semaglutide causes fat loss, but may also lead to muscle loss. And so what the investigators saw was that there was a loss of psoas muscle volume, but really no change in physical function and no change in muscle fat among SLIM liver participants thus far. And then Heidi Crane here at UW represented the CNIX cohort and looked at impact of semaglutide on weight change among people with HIV that was stratified by BMI. Perhaps unsurprisingly, there was more weight loss at a higher degree of obesity, but it was quite significant weight loss. And a point that Heidi made during the Q&A I thought was really interesting is that weight loss was the same regardless of baseline integrase inhibitor use. And again, as we think about our patients and who is gaining weight and who we would like to lose weight, I think thinking about integrase use is going to be really important. So our takeaways: use of semaglutide in people with HIV is associated, as it is in people without HIV, with significant weight loss, can be used for steatotic liver disease, may impact muscle volume, but we'll see how much that matters. We need longer term data, and we need access to the medication. I think many of us have struggled and seen kind of national news about how the pipeline for semaglutide has been really limited, and we really need to be able to access this for our patients with and without HIV. All right, so I'll close things out talking about hepatitis B vaccination in people with HIV. So we have a lot of data showing that Hep B vaccine protection rates in people with HIV are lower than in people without HIV, and this is with Hep B alum or conventional Hep B vaccination. So ACTG 5379, or the Beehive study, was looking to answer the question of would we be more successful with a different adjuvant Hep B vaccine, Hep B CPG or Heplisav, in both people with HIV who are vaccine naive and people who were non-responders previously. So Arm B, the vaccine naive group, has already been presented and published and demonstrated that 100% of people with HIV receiving a 3-dose series of Hep B CPG achieved seroprotective response. 84% of them had a surface antibody titer of greater than 1,000, which is quite profound. And nearly 99% achieved that seroprotective response after 2 doses, albeit at lower titers. So this slide from the National HIV Curriculum reminds us of the study design of Beehive. And again, I'm just noting that we're focusing on Arm A, the vaccine non-responders now. And here, participants were in one of 3 groups, receiving either 2 doses of Hep B CPG, 3 doses of Hep B CPG, or 3 doses of the alum adjuvant Hep B vaccine. I'll tell you that the baseline characteristics in each arm were quite even. Median age was in the mid-40s. About a third of participants in each arm were female. The nadir CD4 median was above 200, and median CD4 currently, or at enrollment, was quite high in the 600s. The majority of the group was virally undetectable, and about 13% had diabetes. And so I think these are the pictures that say it all. So you can see that the primary seroprotective response proportion was higher in both the 2-dose and 3-dose Hep B CPG groups than the Hep B alum adjuvant. So 93.1% for 2 doses, 99.4% for 3 doses. And you can see that both the 2-dose and 3-dose series met superiority thresholds as compared to the 3-dose Hep B alum. And here we can see those anti-Hep B surface antibody titers at the respective time endpoints of each dose series. A darker shade of blue is an increased surface antibody titer. And I think, again, what's quite striking is in the 3-dose series, 96% of participants achieved titers of greater than 100. And I'll note, again, this isn't in this figure, but that seroprotective proportion in Hep B CPG arm remained quite high across CD4 counts, although, again, the CD4 counts were very high overall, and also remained high despite viremia and older age. So takeaways here, people with HIV with non-response to conventional Hep B vaccine achieved superior seroprotective response as compared to 3 doses of Hep B alum. 3 doses of Heplisav achieved a high proportion of seroprotective response with very high titers. And this really begs the question, do we need titers this high? And I think the answer is really, it depends. I've already noted that there was an underrepresentation of factors that are typically associated with poor response. So low CD4 cell count, HIV, viremia, concomitant hepatitis C, and older age. So at least in my practice, I think this will be shared decision-making with certain patients. It is harder to get 3 doses of a vaccine into someone than 2 doses. So that's the other big thing to think about. And then I didn't present any safety data, but there were no unexpected safety issues or death. So I know, again, this was a lot of different topics, but take-home points overall, in terms of thinking about anal cancer screening, a triage referral process, including many factors, may help tailor us to the population who will benefit most from screening and help us get to HRA for those who need it. Semaglutide, maybe unsurprisingly, leads to significant weight loss in people with HIV, but also improvement of steatotic liver disease. And Heplisav B or Hep B CPG is superior to conventional Hep B vaccination in people with HIV who are prior vaccine non-responders. All right.
Thank you all so much. That was fabulous overview. Just as a reminder to our participants, there's a link for the evaluation today. Some applause hands in the comments there. while people are thinking about questions, just to go to Raaka's last study there, do you think there is a case for doing two doses rather than the 3 doses of the Heplisav B, and instead of, I know we're doing that even though the data for the naive patients that came out before had used 3 doses, although 2 doses were sufficient, had high seroconversion. So just curious about the author's thoughts there and your thoughts.
Yeah, I think practically, I think that's a great question. And the one that I think when the vaccine naive data came out, we were all a little disappointed that they looked at 3 dose. I think this is really exciting that they looked at 2 dose. And again, I highlighted that 3 dose, but that graph really showed us that the majority of people really did have seroprotective response after 2 doses. And then whether you need higher than 10 versus higher than 100 versus higher than 1,000, I think is going to depend on the degree of waning immunity we're worried about. But in the 2-dose series, there was still a 70% of the population had a greater than 100 surface antibody titer. So I think for the majority of my patients, at least, and I think this is echoed among many people, 2 doses is enough. And the people who I will be more worried about are people who have low CD4 counts when we're initiating the series, or who have other factors that put them at higher risk of hepatitis B.
Great, thanks. It's interesting because the threshold of greater than 100 in the OI guidelines is really for people with isolated core. Otherwise, it's greater than 10 or 12 or whatever the lab uses here. So it's great if we can get away with 2. Matt Golden commented that it was great talks. It looks like there may be a question here from Nina. Does SF have higher tetracycline resistant GC, and how can we account for the difference we saw in doxypap regarding GC protection?
So the rates of tetracycline resistance among GC are not substantially different in San Francisco compared to Seattle. And I don't know how to account for the difference between what we've seen in the trials and the real world. I feel like I could make up some explanations, but I don't really know.
Great. Doesn't look like there's any other questions from the audience, but I'll give it a few seconds here because we're almost at time. I know, Jehan, you had talked to a number of people about implementation of long-acting injectable therapy, and others are in similar positions, or maybe not at the exact same, in terms of really ramping up implementation. And given the latitude data supporting use in patients who've have struggled with adherence, were there any discussions or studies regarding how to best support that particular patient population and what resources are needed to make it successful in a clinical setting?
Unfortunately, no. Thank you for bringing that up, Shrisha. I think a lot of us, when we saw the latitude results, were really excited. It was a little bit of a, well, obviously kind of a situation, but it was really, really helpful to see that that was true. But I think a lot of us, at least here, we're also a little bit stymied as to how we are going to reach that patient population, because we know that a randomized control trial is very different than real life. And unfortunately, there was not much discussion about what to do. And I think perhaps next year at CROI there will be. And I know that we're thinking about this here as well, because in the MOD patient population and probably also MAX patient population, this is the group in whom we'd like to see it given, but we know it's hard to even outreach individuals, let alone have them come in and get a shot. So I think that is something that I am eager to see what happens in the next few years, and eager to also learn from the rest of this like ATC community.
Great. And then there's a question from Lauren Campbell about if we're offering the option of self-swab for anal cancer screening. So I will say it's not been validated here. We also have not started anal cancer screening. The OI guidelines are coming out very soon. There's just some minor debates. But I will say that if you do not have access to HRA, you shouldn't be doing anal cytology, because what are you going to do with that? And so that's one issue. If you have access to HRA, it depends on your, I guess, the availability and the, if you have limited availability like we do, we actually only have 2 anoscopists currently that work part-time or have part-time clinic. And so based on who would need the screening, it's going to be way too many people that would need HRA based on what Raaka presented and how we risk stratify that. So we actually have some draft guidance here at Madison that we will share soon. And we will be doing co-testing, meaning we will be risk stratifying and making a decision about HRA based on presence of high-risk HPV. But again, we don't have, we have not validated, and we are not going to start with self-sampling for swabbing currently. So there's more information to come in the next few weeks as we are beginning to roll out that program here. Thank you, everyone. We're at time. Thank you so much, Jehan, Julie, and Raaka. Fabulous talks. And thank you for going to CROI and enlightening us with your wisdom from these studies. Thank you.
Thank you
so much.
Everyone, have a great day.
You too.